Hello, my name is Jennifer Weaver, and on behalf of Advancing Evidence-Based Practice, we'd like to welcome you to our May webinar. We're happy to have Stephen Phillippi here with us today and excited to hear him present his Louisiana Evidence-Based Programs Toolkit. Before I introduce Stephen, or before I turn the time over to Stephen, I'll quickly introduce him. Stephen is a licensed clinical social worker and clinically certified forensic counselor. He has a 20-year history of developing, managing, and providing direct care services along the full range of the juvenile justice system continuum of care. In his current role with the LSU Health Sciences Center School of Public Health, Dr. Phillippi is a team member of the Institute for Public Health and Justice, working on a MacArthur Foundation grant to assist in bringing evidence-based practices to local communities. Thanks for being here with us today, Stephen. I'm going to go ahead and turn the time over to you. And it looks like we do have quite a few people in attendance here, so I'll go ahead and give some quick instructions. If you need any help during the webinar, feel free to send me a question and I'll respond to your concern. If you have questions about the presentation, type those in as well, and there'll be points at which Stephen will address those. So we'll now turn the time over to Stephen.
Thanks, Jen. I appreciate it, and I appreciate the opportunity to talk to you all about the Louisiana experience. I take it you can see my screen now?
It looks good.
Excellent. So I appreciate the opportunity and look forward to at least sharing a little bit of what Louisiana has done in hopefully a short period of time. So hopefully I won't race through this and I give time for people to adjust their speakers. I do have 4 kids and I live out in a small farm, so if I'm too loud, you can turn me way down. So just to, I guess, start, one of the things that we certainly want to look at is as people have tried to implement evidence-based practices, they certainly have experienced barriers, and we'll talk about some of the barriers that some of our local sites have commented on. And we are curious in terms of what barriers people are experiencing as they try and implement evidence-based practices. So, Jen, I heard you say that there was several people on at this point. So, can we go ahead and at least get some feedback about some of the barriers through the question box?
That sounds great. So, go ahead and respond to this question here on your screen. You can do so by typing your response into the question box, and then Stephen will probably read those aloud, or I will read those aloud. And we'll give you about a minute to do that.
Excellent.
So what we're looking for here is, what are the major barriers to implementation that you've experienced in your local area or state? We're just waiting to hear from our attendees. Okay, so I've got, what's that, Stephen?
I was going to say, if there are none, that's fantastic.
No, we have a couple. And we'll wait a little bit longer while the others type in their responses. But so far we have that people cannot agree on what to do, and that there are many different versions of what is the best program.
Excellent. Excellent. So both of those are certainly key into some of the things that I hope to share with you today. So that would be good. So Jen, I'm going to go ahead and keep going and moving just for the sake of time, and if new ones come up, happy to address those as well. So just a little background about the presentation today. Just want to talk a little bit about where it all began for us here in Louisiana, why we even chose to focus on evidence-based practices, the platform we use to move evidence-based practices forward, and even addressing some of the barriers that we just heard about. How did we actually draw consensus around some of the evidence-based practices? We have developed tools over the past 6 years that we believe have helped, and we believe we have some evidence to suggest have certainly helped grow evidence-based practices in a very expedited manner. And I am going to conclude with a local example and just give you one simple idea, hopefully, of a fairly large local area that took on evidence-based practices and done it very well. So this is 10 years of Louisiana history in a slide, which is kind of impossible, but just to give you an idea of where we came from and where we are. So MST was kind of the original juvenile justice evidence-based practice, multi-systemic therapy in what we call down here parishes. Most of the rest of the world calls them counties, but in Jefferson Parish, which is right next door to New Orleans. That was in the 1990s that multi-systemic therapy was started first time in the state. And that was right about the same time that Louisiana made a lot of national headlines for nothing good at all, which was our conditions of confinement were deplorable, and the Department of Justice sued the state in 1999 and started what became to be a very large-scale reform of our facilities and our practices and how we manage kids at the deep end of care. Louisiana State University Health Sciences Center, where I work, here at the School of Public Health, took on a contract to help the facilities retool all their behavioral health care, and the state also started retooling how it worked with its case managers, its probation officers, its security guards. Very, very short history on this, but in 2006, very short period of time for most Department of Justice lawsuits, the state was released from the lawsuit having met all the requirements of the lawsuit and improving its conditions of confinement considerably. Around that same period of time, there was a legislative act, Act 1225, which was the Juvenile Justice Reform Act, which then it offered some emphasis to continue the reform efforts in the facility level. It created what we call the Juvenile Justice Implementation Commission, which was a group of leaders that meet routinely at the state capitol to talk about reform efforts. And it also started talking about the broader scope of reform beyond just the facilities in terms of what can we do with probation and status offenders and things like that. Around that same period of time, coming out of the lawsuit, Juvenile Justice Implementation Commission starting the Reform Act, Louisiana Models for Change, came to fruition. MacArthur came in and...
The broadcast is now starting. All attendees are in listen-only mode.
So the Louisiana Models for Change effort started with MacArthur coming in and assessing that Louisiana was right to really take off with change. And they invested in the state of Louisiana to help support continued change. And that occurred in 3 areas, and we were the only state that took on all 3 areas of reform under the MacArthur Foundation, which was looking at disproportionate minority contact, alternatives for formal processing, and also the implementation of evidence-based practices in communities. The conclusion of all that is where we are sitting now, and the gift that I have in terms of my continued work is I'm part of the team for the Institute of Public Health and Justice. Dr. Deborah DePreto leads that institute and has certainly led a lot of the Models for Change efforts throughout the state. And that has been created, and we are up and running, and we've amassed a lot of what we've learned through Models for Change and consolidated it into the institute. And one of our first tasks that you'll hear a little bit more about as well as we go is our first commission task was to study juvenile justice reform in the state and what have we done in the last 5 years and make some recommendations to the state of where it might go. And that was all prepared for the current legislative session that's underway as we speak. So just to give you some visual on the history, as you can see, it's a downward slope, and this is what detention looked like back in 2000, almost 2,000 kids. We were accredited in the New York Times as having the population in terms of more juveniles locked up per capita than any place else in the known world. We have since dropped those rates in Louisiana down to somewhere in the 450s on any given day, sometimes even lower than that. The non-secure placement, not just the secure, what we sometimes refer to as juvenile jails, but also a non-secure placement, which a lot of people sometimes don't look at much because it's not, quote, a jail, but these are kids that are placed outside of their home, outside of their communities typically. Those numbers have also decreased steadily over the past decade. Of course, that raises the question of, then great, so all those kids are now out of facilities, they're back in their communities, what have we done differently? If there's any lessons from deinstitutionalization, it's certainly, there's got to be something available in the communities to help support kids and families to drive down the need for any kind of institutionalized care. So when we took on Models for Change, we sought to increase access to evidence-based practices, specifically in communities. And we wanted to show better outcomes, divert youth from the deep end of the system. And we took a multifaceted approach, which was outcome-driven reforms, and I'll talk to you a little bit more about that, stakeholder awareness, and strategic implementation of evidence-based practices. And I'm just going to walk you through kind of our framework of how we've done what we've done over the course of the last 6 years in the state. We've also shifted from the early stages of this in 2006, which was a heavy reliance on national expertise coming into the state, helping us build momentum, expertise, and reform, to we now have that available here in Louisiana. We have sites that have as much expertise as anybody in the country in terms of what they know about evidence-based practices, how to implement them, and how to move them forward. So when we go to disseminate and grow evidence-based practices to scale in Louisiana, we don't have to look far. We can send neighbors to neighbors and have neighboring parishes, counties go talk to each other and see what successes have happened. Not meant to be an overwhelming slide, but it is. But this is what we work with, and those of y'all that work in juvenile justice certainly know this well. But when we go in, one of the things that we were looking at is when we're talking about building community services, it's not just building community services for the juvenile justice system, but the specific decision points all along the way in the juvenile justice system. How do they make decisions, and then what services make the most sense for that decision point? So that became very critical as we built our strategy and started looking at screening, assessment practices, and then linkages to services when they were needed. This is just a list of many of the different reform models we use that were associated with evidence-based practices. I will not go through them all today. I will certainly highlight a few, but we have brought pilots into drug courts, into schools, contracting models that we've worked with local sites on, we've worked with the state on. We've done partnerships with higher education. Since higher education in Louisiana, there's a lot of colleges and universities that are right there in these local communities. And just like we've been a university that's been working with communities, we teach the local community how to rely on their local university and bring them into this process as well. So borrowing from Peter Greenwood's work, and I know Peter's on the line with us, Peter, I think, summarized this the best, and I want to take advantage of his published wisdom here already. But I think we followed a lot of these steps that Peter talks about in terms of implementing EBPs and growing them to a statewide scale. We certainly turned crisis into opportunity. The Department of Justice crisis, with having to get kids into better care, having to get kids that did not belong in facilities out of facilities, and taking advantage of that momentum to emphasize more community practices. We also had the unfortunate crisis of Katrina, but in a way it was, as much as it was a hardship, it was also a blessing. I mean, we got the opportunity to rebuild a lot of community practices, and that was right there in 2005, and MacArthur's here in 2006 as we're trying to rebuild infrastructure in communities that could respond better and support probation and support alternatives to formal processing, keep kids at the more in their community and more served by their local needs served by in their local community. We'll talk about structure involvement of stakeholders, so I won't dwell on that. Like I mentioned earlier, we've developed local expertise. It wasn't to constantly trying to have sustainability of this by relying on outside sources. Just didn't seem to be a sustainable plan for us. So we have developed our own local expertise and encouraged people as we've gone in to take what we have to offer, but then to take off for themselves. They don't need us, and that's the goal in all this, is to get us out of the picture and allow the locals to really run with this model. We've pilot tested it. I know a lot of states have run through with mass movements, and I don't know which one's right or wrong. I think they both have shown some effectiveness, but we have done this by going into local sites, creating pilots, really creating lessons learned, tweaking the effort so that when we take it to the next step in dissemination, taking it to scale, we have very refined sites that we can refer people to say, these folks have worked through these same issues, and the lessons learned and everything else to hopefully expedite it in the next site as we go in. We've created the Information Resource Center, which at this point in Louisiana is us. It's the Institute for Public Health and Justice, where a lot of this is contained. In terms of funding and designation for evidence-based practices, I'll mention that earlier as I get to the local examples and some of the state examples, but we've transferred a lot of funding that was going to non-proven programs before, and we've redesignated or reconcentrated that around programs that have evidence of effectiveness. So just to jump off of also where Peter has published, so we were shocked to see this, honestly. We had no clue. But when Peter did his national review of evidence-based practices, specifically multi-systemic therapy, functional family therapy, and multidimensional treatment foster care, we were surprised to see that we landed up there in the top 3 or 4 of states per capita in terms of implementation of evidence-based practices. I think the most interesting thing here is out of those states that are in this upper end of the diagram is we've probably done it faster, which certainly piques our curiosity. What was it about Louisiana that sent this accelerated dissemination of evidence-based practices versus states that have been doing this certainly a lot longer than us and had a lot more expertise and knowledge in terms of building and sustaining evidence-based practices. So with that, and I just go to the consensus, and then I'm going to get into the tools that we've used. We've done this 6 years momentum. We've built up evidence-based practices in Louisiana, and it's interesting because taking this to consensus, as an institute, we've gone out and we did consensus building meetings as we were approaching this legislative session, just because we were being asked to make recommendations to the state about what's next for juvenile justice reform. And even in all this movement and getting evidence-based practices and pilots started, it was the #1 issue as we walked around the state in 2012, met with judges, district attorneys, brought them all to the same table, by the way. This wasn't private meetings. These were large group meetings of DAs, public defenders, judges, probation officers, and other stakeholders in the system. And it was consistent in 2012 that we still, as a state, want more improved services for the juvenile justice system. And some of the specifics that came out of that were access to services. So not only that the services are here, but we can get to them. It's interesting because one of the lessons learned is the services can be in your backyard, and sometimes nobody's referring to them. So there's just to create an evidence-based practice certainly isn't enough. But also creating the specialty services needed that are distinct to juvenile justice populations. So we know that there's educational programs out there that are certainly evidence-based practices, but what are the services that are most likely to have the greatest benefit for severe delinquent, your moderate delinquents, your status offenders, things like that. Continuing to look at the gaps. That we started a good thing. We've gotten a lot of momentum around evidence-based practices, but we know that the gaps are still there and they still exist. And we've set up a monitoring system that I'll show you some of the results of. But we have a way now that we can more quickly go to areas and look at where the gaps are as services are created, as services shut down, and things shift in the system. Mental health needs. We are like everywhere else in the country. The mental health needs of kids in the juvenile justice system are extensive, and trying to figure out systems that are better in responding to those, identifying them and responding to the mental health needs of these kids. So it's not kids just showing a graduation, a trajectory deeper and deeper into the system before somebody recognizes that this is more of a mental health need than a juvenile delinquency need. And Louisiana, like many states out there right now, are also looking at the issue of crossover youth. These kids are already in state care through the Department of Child and Family Services, and we certainly are curious why so many of them transfer into the juvenile justice system, and how do we stop that? They're already in state care. Why can't we care for them where they are instead of reinventing and forcing almost trauma in these kids' lives by putting them into just another state system? So the tools we've used to do this, and this is, as I mentioned, this is 6 years in the making. We certainly think we have something that is effective. We also have something that we continue to develop as we go. They're all based on those 3 platforms that I mentioned at the beginning, which is stakeholder awareness and education, gathering data and using data that's available to drive reform, and then a very strategic way that we work with local communities to help them implement evidence-based practices as they move forward. So we talk to people, stakeholder educational awareness. We will talk to anybody that will listen to us. We have held numerous meetings. We actually launched this whole thing with a summit in the state capitol. Invited local representatives, legislatures, judges, any professional group, DAs, and we started educating in 2006 around what are evidence-based practices. Just start at the beginning. That these are research-driven. They are not perfect programs, but they're proven more than treatment as usual. We can keep kids out of the system. We can keep kids in family. They're cost-effective. They're quality programs. They have better and more diverse outcomes in a lot of ways. So we would talk to anybody that would listen. So we did that in in-person meetings. A lot of these we were invited to. A lot of these we created. So it was certainly a shared effort as we went around the state and offered information about evidence-based practices. We had paperwork to support it. We would do white papers and fact sheets, and we have lots of these. These are actually, several of them are on our website. But we did white papers for the legislature. We've done fact sheets to keep it brief and to the point, no more than 1 page front and back, about cost, about effectiveness. And we certainly disseminate those to local areas, to professional groups, professional meetings. We also take the opportunity of op-eds as issues come up. One of the roles that we have as an institute and as a state entity here at Louisiana State University is to inform and educate. So when we have groups come to us and say, hey, what do you think about this issue? This one was a detention center. Detention centers in Louisiana were consistently reducing their populations in beds. We had, out of nowhere, a detention center want to increase its bed, and it actually got funding for it at $6.57 million. So we helped the local advocacy group at their request to just break some of that information down and tie it back to evidence-based practices. So the price per bed at $6.5 million was $55,000. So we simply broke that down. How many kids not just would get a couple of nights stay or a week stay in detention, how many kids would benefit from Big Brothers Big Sisters or functional family therapy or multi-systemic therapy or multidimensional treatment foster care, et cetera, versus just getting a stay in detention, basically doing their time. And this went out in the Times-Picayune, which was a local paper, and certainly has been carried also by representatives that have used the same information as they've gone out and done talks and speeches and release their own information. So we try and get the word out. So educating stakeholders is the start. The second piece goes into the data, because we want to walk into an area and we don't want to make anecdotal judgments about what an area needs or anything else. We want to know, based on their information, based on their data, what do they need. So it takes us back to this slide of the juvenile justice system. So we literally go in and we have a process, what's called a mapping process, and we go through every one of these points, from arrest to kids that are referred to as status offenders, kids that go to the DA's office, kids that are diverted versus kids that go to court, how the judges decide to do what with kids, who goes to detention, and we count how many kids hit every one of those points in the system, how many kids continue on down the system, and how many kids are referred out. And then we know from just a sure impact of how many kids we're dealing with when we look at status offenders. We also, as we do these counts, we also go in and try and find out if ideally there's any reliable and valid screening or assessment instruments in place where data might be available for us to mine and say, what are the risks and needs of these kids? Do they really need services? And if so, what services might be most beneficial based on their objective assessed or screened needs? Where that's not available, we encourage people to start using screening and assessment. That becomes one of our gaps when we do the analysis of the local area. So we start encouraging them to implement screening and assessment processes that can gather those type of data and take them to the next level of really becoming a data-informed, research-driven, data-informed process, even if we can't do it at the initial, in the initial contact with the site. Not just the juvenile justice system, we also tap into the provider network in local areas when we go on. We've done this all the way from local areas now up to state surveys based on our work with different organizations like the Office of Juvenile Justice here in Louisiana. But we go into local areas, we use their local probation, we use their local courts, and we say, who are the providers you're using? And we survey them. And we work in concert with the local area to get surveys out to providers to ask them about what practices they're doing, the kids, where they're getting their referrals, what type of services they're rendering to what type of kids, what kind of issues are they addressing with services, whether they believe those services are evidence-based practices. And we have a series of questions that also reinforce whether it's really an evidence-based practice or not. You know, is it based on research, externally researched programming? Have you been trained on it? Is this an internally developed program? If it is, you know, do you have data on that program that can say whether it's effective or not? So we mine the local providers for a lot of information, and we've had some great participation on this. It becomes a wealth of knowledge for us as we continue a planning process with the local area. We also ask them about their funding sources, and their capacity, their type of staff, the level of training of their staff. And just to give you one example of what this can do, these reports that we provide to the local areas are certainly much more extensive than just one graph. But I love this one, especially for you all out there that are doing evidence-based practices. I have used this more so than not just as a great visual. This was 100 providers. This is one of our initial surveys. We went into an area, and this is strictly on self-report. So these are people that say they're doing evidence-based practice, people that are admitting that they're not doing evidence-based practices. And the difference between these, when we talked about, you know, out of 100, we had probably about 15 to 20% of those folks come back and say on their self-report that they were evidence-based practice. And the vast majority of responders to this that said they were working with juvenile justice kids, they get referrals, the vast majority said they were not using evidence-based practices, and that's strictly on self-report. And here's a great visual example of the difference. So then we start asking them questions about their programming. Do you have treatment manuals? Do you have structured training? You know, do you monitor your processes and track fidelity of your services, things like that? Do you monitor your outcomes? And you can see the purple on here, the difference between those that say they're evidence-based practices and those that aren't. It's striking. So we use information like this in local communities and say this is about quality. These are quality programs, kids get better quality intervention, better services, and everything else. And I'll just give you, it's not on my, it's probably a subject for a different discussion down the road, but one of the interesting things is as we've pushed evidence-based practices more and more in Louisiana, even the non-evidence-based practices that continue to be honest and open on the surveys, we've done this now 3 different reapplications of the survey across the state, we're seeing even the gold lines start to come up because people are starting to get the idea, even beyond evidence-based programming, that can be purchased and certainly implemented. But providers that aren't doing evidence-based practices or maybe can't because of their capacity, they're also improving their services because they're paying attention to the quality that's needed and being demanded from the system now. So we also, like I had mentioned earlier, we crosswalk with available data as we go into areas. In Louisiana, while we're doing pushing for evidence-based practice, evidence-based programming, we've also equally been pushing for research-driven screening and assessments. We help the state probation offices. We started with local probation officers. It grew to a state effort, but we've implemented throughout the state at this point the SAVORY, which is the structured assessment for violence risk in youth. And this is just looking at the statewide data. We know that based on the risk level of kids being now screened throughout Louisiana, that most of the kids in our system, these are all kids on probation, these are all kids that have been adjudicated delinquent and are on probation, are either headed to a secure facility or staying in communities. We know the minority of them are not at risk for violence, at least not at high risk for violence. So that communicates well the need for continuing to build community programs because that's where these low and moderate risk kids need to remain. They don't need to be in facilities. The SAVORY also helps us identify some of the general, and I admittedly these are broad general areas, but what are the needs of these kids that are on probation? So out of 1,100 probation kids that we looked at in 2011, the Office of Juvenile Justice, the greatest area of needs, the highest area of needs noted through their screening and assessment was disruptive behavior, mental health needs, again, and peer association needs. So again, this starts communicating us what do we need to start building to address the needs of juvenile offenders in the state and in local areas, since we have this information at the local level as well. We've also looked at the trajectory of these kids. Are we stopping kids that have severe needs, in this case mental health, substance abuse needs, from getting in the system? And back in 2006, we weren't. These kids were being placed at high rates in the system, and we were outpacing Texas and Washington back here in terms of the rate of mental disorders, any kind of mental disorder, and substance use disorders hitting the deep end of our detention centers and our correctional facilities. So we have a series of education, as I've mentioned. We have a series of going in and mining data, helping create areas' capacity to develop their own data, to look at where their kids are, what the needs of their kids are, and then we go in there with the strategic implementation. So all of that data then becomes information that we bring back and give feedback to local areas, regions, so that they can start making decisions about strategic implementation. So many of you all know, I'm sure, Patrick Canary's done a phenomenal work out in Ohio. He came in and he and I worked together, and we developed an evidence-based practice selection guide. And it's really just it's a structured questionnaire. As we go into communities and we start talking to them seriously about evidence-based practices, those of us that have done this and helped implement evidence-based practice know that there's this thing, it's my favorite term in the world around evidence-based practice, but there's this thing called uninformed optimism, which is you go, you hear about all the great outcomes, the great practice, other areas are doing this so well, and it's like, yeah, we want that for our area. Well, it's, as we all know, that's not quite that it's not quite that easy. You know, once you start jumping into evidence-based practice, really trying to implement them, trying to sustain them, you get into informed pessimism pretty quickly, like, oh my God, what did I get into, and can I actually pull this off? As we've seen over and over again in sites, you know, you stick through that, you do get back into informed optimism, and you get to that sustainability. But this was just a tool to help ask very, very hard questions of the area to say, are you ready to do this? And not only are you ready, but what's the practice that's going to fit your local needs based on the data that we help you gather? What's going to fit that need the best? So it's not just MST or FFT or brief strategic family therapy coming in and doing an incredible job showcasing their practice, but does that practice actually fit the gaps and needs that we've identified in your local area based on the data? So that the guide, and again, a lot of these tools are available on our Institute website, but the guide covers all of these areas, from what population are you really trying to target, age, gender, is there any other contextual issues that need to be considered about the population you're trying to target? Are these status offenders, are they delinquent, or is this an aftercare issue, or is this a diversion type population? What funding's available or could be available? The level of collaboration, who's going to be the leader on this? Who's going to take charge of this and really see it through? What's the level of evidence about the programs that you're considering, et cetera. So we go through a lot of difficult discussions with folks just to get them really knowing what they're stepping into and having that much more ready once they identify the program and say, yes, this is where we want to go. And we do this as an area. This isn't with an individual provider. We do this with the judge, the DA, the public defender, the providers that are available, and we do this as a collaborative local effort. Once we identify programming with them, again, we are constantly doing this parallel work with screening and assessment. So we're also saying, okay, if that programming is what you need to fill a gap in your local area, we also want to know that you're getting the right kids to that program. So what valid, reliable screens are available or assessments are available that point the right kid to the right program? So if we've got a moderate need substance abuser that comes through, we certainly want to get him to the right services. We don't need to send him inpatient, but maybe there's an FFT or an MST approach that could come in. Even for some of our high substance abusers, maybe MST is a good fit depending on what their specific needs are. The low offenders, it's very consistent when we do these matrices. On the low risk, low need, we want them to stay away from services. We don't want them to associate with higher risk and higher need kids. We don't want the social learning going on that we know that is part of most juvenile justice systems. So low risk, low need kids, we want to keep them as far away from services and out of the system as possible. So that's the other help, is we don't put kids that don't need services into services. So we're using the right services, the right fit of services with the right type of kid based on his or her needs. The other thing we've done in most local areas is there's a policy associated with these matrices, which is we don't take over the local expertise. If a probation officer, a law enforcement person, a judge, a DA, anybody wants to override this, they can. But we try and put in policies at all of those levels that if it's overridden, the consensus of the group is kids that, for example, kids that have high family conflict needs. The best practices might be brief strategic family therapy, MST or FFT, something like that. If somebody chooses not to send them to one of the programs that are identified appropriate for that risk and need, they're welcome to. But we ask them to put in policies and practices where it's justified. So we can start going back and looking if people aren't utilizing it, why, and what's the override for. And there's data to come back as systems continue to develop, systems continue to grow, to say, why aren't you using these services? And we go back and we can look at documentation about justification of override decisions that the group had decided to make. What we find is there's very little overrides. Once the consensus is made in local areas, more often than not, it is the general theme that's continued and maintains stability. As I mentioned, we've done the provider survey now at 3 reassessments, and 2007, 2009, 2011. So back in 2006, when we originally put it out, the survey, and we reported on the results from 2006 and 07, you could see that kids in Louisiana, this was had less than, it was a 1 in 5 shot. So 4 out of 5 times you wouldn't have got, if you were in juvenile justice, you wouldn't have gotten to an evidence-based practice. as of 2011, which we reported out last year to the Juvenile Justice Commission, we're almost at a 50-50 shot. So in just a short 6 years, that's incredible. I mean, we're very proud of it, very excited about it. I love the fact that kids now have a half and half shot of getting an evidence-based practice. Is that good enough? Not even close. And we have a lot of consensus around the state to certainly increase that and continue to watch that bar hopefully rise. Just another visual example as we've grown practices. As I mentioned, MST was the first practice in terms of juvenile justice evidence-based programming that came into the state. And back in 2006, we had about 200 families being served by 6 teams throughout Louisiana, and not one FFT team. As I had mentioned, we go in and we don't dictate practices. We ask providers and we ask stakeholders what are their local needs, what do they, and we give them a comparison of programs that could fit those needs, and they make the decision. So I'm going to show you just one way that this has been levied. We did that about 4 years ago. There was a small amount of money that was available from the state. It amounted to about $260,000 that they offered to some of our local sites to say, if we could help you implement an evidence-based practice, what would you like to implement? And we showed them several, and the providers landed on functional family therapy. So we had 5 sites that said we would love to use that $260,000 to get licensed, start building FFT, which didn't exist in the state at the time. And after going through some of that initial, are you really ready to do this, very proud to say that out of those 5, one of them withdrew with money on the table that they could have spent. They said, we couldn't sustain this. We don't have the infrastructure. We're not ready. So they withdrew from the funding. Proud to say that they are now back and they're one of our FFT providers. But hats off to them for being smart enough and strategic enough to know their own limits. But so we started in 2006 the selection of FFT. It certainly wasn't to the demise of MST either, because MST continued to grow. But this is what it looked like in 2011. So we went to 36 MST teams that have been supported various ways throughout the state. Almost 2,000 families being served by MST annually throughout Louisiana. Functional family therapy went from 0 to 8 teams, with almost 400 families being served annually. And a lot of this has been moved now additionally under our Medicaid funding options, which certainly hadn't always been there. Speaking of funding options, one of the ways that this also happened is, although you can see we suffered the same recession that everybody has throughout the country, so this doesn't represent the amount of dollars, but the percentage of dollars that certainly where dollars were being dedicated. 2006, it was clear that most of the dollars in the state were going to residential, foster care, correctional facilities, things like that. Also, juvenile justice in that short 6-year period literally flipped the entire proportion of its money. Now, the money went way down as recession happened, cutback happened, but the emphasis became on keeping things in the community and not on the facilities. This was another, just like Peter's slide about us being up there in terms of our use of evidence-based practices per capita. This all makes it worth it. When we look at, is this at the demise of our public safety in Louisiana? The answer is no. Juvenile arrest rates have been going down in Louisiana. If you look at the 2006 mark here on your screen, that's when we started all this, and we've had sharp drops in juvenile arrests around Louisiana consistently for the past several years. So, so evidence-based practices are going way up, arrest rates are going down, and I think that's almost enough said. I should cancel the whole talk at this point. But just to give you our local example, just to show how this also, we do a very strong effort to build local capacity and move it up. And Jefferson Parish is right next door to Orleans, has certainly been one of our champions of moving forward evidence-based practices. So when we went in, did the provider survey, looked at their decision points and all, their provider survey came back and said only 12% of the kids that were being referred to programs in their area from the juvenile justice system, only 12% were actually receiving, and this is based on self-report of the providers, not us going in there and checking whether there were actually evidence-based practices, so it may have been much lower than 12%. but only 12% of their kids were getting to an evidence-based practice. Roy Junker, who I know is on the lineup, and John Riles for later in a presentation with Advancing Evidence-Based Practices, championed this cause, and I was very proud. I sat in when we presented these data, we were at a Child and Youth Planning Board in Jefferson Parish, which brings together their DAs, their judges, their public defenders, their providers. It's a routine meeting that they have, and they presented these data. And Roy Junker stood up as the head of their Department of Juvenile Services and said, this isn't a good, 12% is never going to be good enough, and that's going to be our baseline. We are going to beat that every year, and that's exactly what he did. It wasn't without a lot of issues. They had to really take a serious look at the practices in place not being evidence-based practices, the fact that they were duplicating a lot of practices, evidence-based or not. They had severe gaps in their services, and one of the things that they discovered, which certainly has been helped by evidence-based practices, they weren't family-friendly in terms of when practices were offered, where they were offered, etc. So they looked at their barriers. There was a limited knowledge that emphasized why we had to go in and do stakeholder building and awareness. There was little motivation to change. You've always paid us to do these practices. Why should we do anything different? There was lack of training of professional staff and providers in the area to do anything different. So you got a lot of feedback, and there's just two quotes here that came out of Jefferson Parish. I'm not giving up what I believe works to try something new that might not work. Sure, I've been doing this for a long time. I think it works. But these are comments from their providers. It's not possible to get individual and family to participate in a program like this. It's too intense. It's too different. But they were successful. I'm going to show you how successful in a second, but it was because of leadership and management, and it wasn't us. We were just there to support them. It was because of the local leadership and management. It was because of collaboration. Realigning the resources that were coming into their community to emphasize evidence-based practices, and then really aligning the interventions that were needed with the needs, not just sending kids because they were on probation to a program to say they were getting something, but really linking assess needs with programs that were available to fill those needs. And so they've implemented a lot of evidence-based practices. This is just a short list of what is available now in Jefferson Parish to their kids that are on probation. And this is what it looked like. So after we had that initial meeting back in 2006, 2007, the probation kids, the kids that the probation office had control over, looked at just those kids that they had control over, not necessarily, status offenders, all that, just the probation. They said, we're going to change the way we refer. So in 2007, they were able to identify that they were only referring 7% of their probation kids to evidence-based practices. By 2010, and this continues to this day, over 95% of the kids are now referred to evidence-based practices. They get it, and this is where they want their kids to go. And this is what they've restructured their referral network to certainly emphasize. They also put their money where their mouth is. So contracting that comes through their probation offices for services for their probation offices. Back in 2006, 2007, less than 10% of the kids, or their contract dollars, were going to programs that were identified as evidence-based practice. Today, they're pushing 100% of their contract dollars going strictly to those that can identify as an evidence-based practice. Again, not dictating what practices those are, but making sure that when somebody applies for a contract in that county, that they can identify as an evidence-based practice based on what evidence, based on what needs they plan on filling for the kids on probation, etc. Like the state, they haven't seen a rise in crime either. So all the way back to 2009, 53% of recidivism on their probation caseload is now down to 21%. And I know there's charts all over the place, but this is because it's monitored so closely, and you'd certainly have much more of a smooth trend line if you just looked at it probably more in the year to year or 6 months. But you can see it goes up and down, but 21% it is trending, consistently been trending down to keep kids from recidivating that are on probation. Anyway, this isn't just in Jefferson Parish. This is in Caddo, Calcasieu Rapids, Washington Morehouse, 16th Judicial District, which is a district out by Lafayette. These are some of these are metropolitan areas. Some of these are very rural areas. So when we have developed pilots, we have places in the state to send as we try and grow evidence-based practice, send to. If you're a rural area, we can go send you to Rapids or the 16th JDC, and you can see what rural implementation of evidence-based practice in a rural context looks like. If you want more of a metropolitan, I can send you to Jefferson or Caddo, et cetera. So we've used our pilots, and those are certainly a cornerstone that helps us disseminate further. So just to sum up, just as I know we're running out of time here, yeah, it certainly isn't perfect. We've learned a lot, and we continue to learn, but we are growing. We've taken the Juvenile Justice Provider Survey, and now we're applying the same things that we've learned in juvenile justice to the broader behavioral health community, and we've got a very large-scale pilot going on with that. But we continued the same three platforms, that this has to be stakeholder, have to be educated. It has to be driven by data and information that's available in local areas, and we certainly, these implementation decisions are tough, and it takes a lot of support and a lot of guidance to make the right one, and then get to the point where it's sustainable. So, so with that, we really would want to just wind down and kind of close. I know it's a lot of information in a very short period of time, so I appreciate you guys bearing with me and everything. Jen does have a final poll question that I believe she's going to post now. But based on what you've heard today, what are the areas that interest you the most that could possibly help you advance evidence-based practices in your local area? We're curious. Certainly, you've heard the Louisiana experience. We'd love to hear the experience of others. So, Jen, if you want to go ahead and do the poll.
Sure. So that should be up on your screens now. And just like Stephen just said, the question is, based on what you heard today, what are the areas of most interest that could help you advance evidence-based programs? And you can check all that apply, so we'll give you a few minutes to complete that. We're almost complete. It looks like most people are saying that stakeholder education and awareness definitely plays into this more than anything else, followed by data-driven decision-making guides.
Excellent.
Okay, I'm going to close the poll. Thank you very much for attending our webinar. Stephen, did you have some closing remarks?
I'm just going to say thank you as well. I mean, we are excited about what's happened in Louisiana. Certainly have learned a lot of lessons and have a lot more to learn, but certainly benefited from a lot of folks nationally, other states. And we look forward to continuing to collaborate with not just in Louisiana, but nationally. So if there's any questions or need for more information, feel free to contact me, and also visit the Institute for Public Health and Justice website. A lot of this information is there as well. And I appreciate the opportunity from you and Peter, Jen. Thank you.
Thank you, Stephen, for being with us today. And you can find a recorded version of today's webinar on the Advancing Evidence-Based Practice website. And also join us next month. Alicia D. Brooks will be presenting on recruiting and selecting therapists, and she's from Community Solutions. Thank you and have a great day.